Our next talk will be given by Dr. Ardill, who's already been up here, so I don't need to introduce her. You know her very well. She's talked about quality of life, but Dr. Ardill is one of those multifaceted personalities who not only talks about quality of life issues, but is a bona fide biochemist, which is also part of what pathology is all about, diagnosing disease. And Joy will tell us now about some novel circulating markers in neuroendocrine tumors. Joy?
Hello again. When I got this title, I believed that it was not just looking at what we know at the moment, but looking into the future a little bit to see where we might look for new markers that would be novel. So I'm going to do a little bit of looking back at the past and a little bit of looking forward at the future. Well, what are the advantages of circulating markers? We've just heard from the last talk that they're not necessarily the quickest of results. In fact, some of the scans are really quick. But we don't always have those scans available. The markers can be repeated really frequently, and in some patients where we've been looking at treatment, we've maybe taken a blood sample, a very small blood sample, just 1 ml, maybe every week, to follow how a patient's responding to treatment, so that they can be taken frequently. And there's no invasive testing. If patients are going to have CAT scans every 3 or 4 months, then there's a little bit of a dose of radiation all the time. If we're going to do repeated biopsies, that's quite invasive, and a lot of folk are very unhappy about having very repeated biopsies. So in fact, circulating markers are quite ideal. And we have a large battery of these as possibilities. Why do we want to have circulating markers? Well, we want to screen new patients. Screen is a bad word there because, in fact, when you're looking at tumours that are not rare but very uncommon, it's not going to be cost effective to go out into the shopping malls and screen everybody who walks by, because we're only going to get one in so many 100,000. So that's not a possibility, but we're going to look at patients that have had some history or are probable patients. Then the next thing we want to do is to monitor these patients once they've been diagnosed and once they've had treatment, maybe after drugs or after some intervention or for recurrence. We want to monitor these patients. So we want to find an ideal marker for a particular tumour or a particular patient, and we want to monitor that after treatment to see if we're getting rid of the marker, in other words, the tumour is regressing or not being active. And we want to see if it's coming back then. We also have got very interested in prognostic indicators, and this is something that I find really interesting in the laboratory. Because we know that some of the tumours are very slow growing and some are really aggressive, then we want to be able to work out how these tumours are going to develop. And maybe we will have predictors. This is something we don't really have in the future. I'm going to talk about this towards the end of the talk. Maybe we'd be able to predict how certain tumours will respond to certain treatments, so we could predict. So we're going to look at prognostic indicators. What markers do we have? Well, we have Chromogranin A, which is the best general marker, but we've heard this morning that in fact there are some problems. Lots of people have raised Chromogranin A, and we know that lots of people take proton pump inhibitors. In fact, in the UK, they can be purchased across the counter. And some people take them if they've had a bit of a drinking binge at the weekend. Students do this, and they maybe take them every weekend. So in fact, we're stimulating the gastrin cells to stimulate the ECL cells to produce Chromogranin A. And we find some patients will have, quite a lot of patients, they will have twice the normal level, 3 times the normal level, but some patients will have about 100 times the normal level. And if we take them off the proton pump inhibitors for about 2 weeks, they'll come right down. And then you put them back on again and they come back again. So this is a little bit confusing. It means we can get what we call false positives. We can do a Chromogranin A test. It looks really very high, and we think it's in a tumour range, but in fact it's because of proton pump inhibitors. And there are other reasons too that Chromogranin A can be high. Tumour talked quite a lot about pancreastatin, and that's a little piece of chromogranin that is generated naturally by the body and is found in quite high concentrations in tumour. It's pretty well undetectable in the normal patient, in the normal person who doesn't have a tumour. We're all normal. Chromogranin B, there's a family of chromogranins, and we're beginning to look at some of the other chromogranins, and chromogranin B is another possibility. So all of these are screening and monitoring disease. The tachykinins, which is a group of little tiny peptides, and in fact the most common peptides in the animal kingdom, they're found in frogs, they're found in pandas, and they're found in human beings. And there are 3 in human beings, and we have followed the one that we find most stable in the blood, which is neurokinin A. And then there are specific markers, and we've got really sensitive methods, which is called radioimmunoassay. We use an antibody, and that gets very specific for that particular peptide, like gastrin. And we use a little bit of radiation, which gives the sensitivity. And between the specificity and the sensitivity, we get a very, very accurate measurement of particular peptides. So we can look at things like gastrin. And some of these have been looked at for prognostic indication. And there's some strong evidence that chromogranin A is a prognostic indicator. In other words, when chromogranin A is high, then there's a worse prognosis. When pancreastatin is high and rising, there's a worse prognosis. And we have also found with the tachykinins, for a particular group of tumours that we've been commonly calling the midgut carcinoids, the serotonin-producing tumours, they also produce the tachykinins, and there's a prognostic indication there. And I'll show you a little bit more about that later on. So looking for new markers, where might we find some new markers that we haven't thought about in the past? Well, newly discovered peptides, maybe old markers that we can have another look at again. The Granin family, which is getting to be quite a big family. There's several granins, Chromogranin A, Chromogranin B, Secretogranin 2, that we have quite a lot of information about already. And maybe some new markers directed towards therapy options that we are just beginning to think about, perhaps because we're getting more therapy options. So what about newly discovered peptides? Well, if we think of something that's reasonably newly discovered that you will all have heard of, I think you've all heard of ghrelin, because ghrelin is the bad thing that comes from the stomach that makes us all fat, that we try to struggle against. It was discovered by a Japanese researcher in 1999, and you'll see that, in fact, we've already had ghrelinomas. So this would be a specific marker. If a tumour was producing ghrelin, then it would be an ideal marker to use to follow the progression of that tumour, to follow it after treatment, just like gastrin with a gastrinoma or insulin with an insulinoma. So as we find new peptides, then sometimes it's worthwhile to measure these, but in fact ghrelinomas are exceedingly rare. We can look at old markers with a new perspective, and this would be the tachykinins. I'm doing this very badly at the moment, am I? We find that the tachykinins were discovered really quite some time ago. I said they're common to very, very many of the animal kingdom, all of the animal kingdom, as I say, frogs and snakes and spiders, I think, too, have tachykinins. Neurokinin A was discovered way back in 1985, and in fact it was looked at that time, or very soon after that, by Kjell Oberg and his group, and it was found to be raised, all of the tachykinins that are found in humans, neuropeptide K, neurokinin A, and substance P, all 3 of those are found to be raised in patients with midgut carcinoid. But we had another look at that in a big retrospective study in Belfast, which was published in 2006. And we found that, in fact, this is a really interesting prognostic indicator. We used an antibody that looks at the C terminus, which is one end of the molecule, and in fact picks up 2 of the tachykinins very nicely. Now, predictive indicators are very important because if we look at the scan on the left, then we see that that's very often what we see with an octreotide scan. And very often, if you look at an octreotide scan in a patient after with midgut carcinoid after 5 years, it's going to look exactly the same. But with some patients, in fact, it goes to the right-hand side, maybe after 6 months. Now, we can't scan every patient every month, but in fact, we need to know what's happening with tumours. We need to know the ones that are indolent. I can think of one man who has had a midgut carcinoid, I think, for 32 years, and he is absolutely static. There has been no change in his disease. He has disease in his liver, and there's been no change over that period of time. But that's uncommon, and in fact, it's somewhere in the middle. Some patients will progress in a few months, but it's somewhere in the middle. So we've been looking at neurokinin A as at the diagnosis and according to metastatic spread, and we find that in fact when there are no mets that we can see in the liver, then the neurokinin A is within the normal range. It's just the same as everybody else out on the street. If there's local lymph involvement, then it's just about pushing the limits of the normal range. If there are distant lymph involvements, then it's getting above that range. If there's up to 4 liver mets, it's clearly above that range, and if there's more than 5 liver mets, then it's way above that range. So it measures the amount of disease, and rather than the volume of the disease, more the number of metastases. If we look at 3-year survival rates in patients that have a neurokinin A in the normal range, therefore we're looking at patients with not so much metastatic spread, or no metastatic spread that we can see on scans, then we find that the 3-year survival rate, and this was on a retrospective study, and this was deaths from all reasons, not just from neuroendocrine tumours, then we find that it was about a 90% survival rate at 3 years. With patients who had a raised neurokinin A and up to 63, we divided the group that we had, which was about 73 here. We divided them into 3 exactly equal numbered groups. So that brought a group of patients with neurokinin A 20 to 63. Then we find that their 3-year survival was somewhat less. And we find that patients with a neurokinin A in the top third, which was over 63 nanograms per litre, then their survival was very poor. Now, this, in fact, was looking in a retrospective study where we weren't intervening very rapidly. We've got much more proactive. We found another thing that was really interesting in this study, that neurokinin A was the only independent indicator of poor prognosis. In other words, it stood alone. We didn't have to know the number of metastases. We didn't have to know the chromogranin A. We didn't have to know some other things about the patient. It's also extremely specific. We don't find neurokinin A raised for other reasons. And the most recent neurokinin A was the best indicator. Now that raises expectations fantastically, because I don't have to tell you, if we can then change the neurokinin A, if we can make a high neurokinin A be low, then we have changed the prognosis, and that's really very exciting. So we have done this in a prospective study which is going on, and the numbers are somewhat smaller here, but in fact that every patient that comes in with a midgut carcinoid now, that we look at the neurokinin A, we treat their tumour load, we treat their symptoms, and we treat their neurokinin A. We make every endeavour to get it down below 50, definitely, and lower if possible. And we're finding that with the same 3 groups of patients, and this group fell into virtually the same 3 groups when we divided them in 3 parts. In the turquoise blue colour, we're seeing that survival is greatly improved. It's improved in the patients with the low neurokinin A's. It's improved with the patients in the mid-range, but it's phenomenally improved in the patients with the high neurokinin A's. And that's because we have used all treatments that are available to us to lower the neurokinin A when at all possible. So that's quite exciting. So we can change things with patients, and we can use markers to really monitor this very accurately. So, to go back to the slide at the beginning, where might we find new things? We might find new things in amongst the Granin family. I've said there's Chromogranin A, and we know a lot about Chromogranin A. Kjell Oberg's group have looked at all of the fragments that naturally occur from chromogranin A. All big proteins have what we call cleavage points, and that is where they tend to, enzymes tend to break these up naturally in the body. And in chromogranin A, there's a good few of these, and we've got a good few peptides produced. And many people have looked at all of these peptides to see if they have some function and to see if they'd be good markers for neuroendocrine tumours. And apart from pancreastatin, we haven't found any that are particularly exciting, perhaps. Then there's chromogranin B, which circulates in much lower levels but is quite interesting and has some virtues. And secretogranin 2, which is again in very low levels, secreted by the tumours, and may have some virtues. So we might find some interesting things when I look in a crystal ball amongst the Granin family. Now, the chromogranin A's are quite easily measured. They were a bit of a problem to us to begin with because people who work in the laboratory, like me, could measure very small amounts of very small things using this technique of radioimmunoassay. But when we were faced with a bigger molecule, we found this quite difficult. But we now have very good and reliable assays, and I think Tom Odorizio was saying that if you get a chromogranin A measured in one place, make sure that the next chromogranin A is with the same assay in the same centre, because something can look like 10 one place and can look like 100 somewhere else. So you have to be sure you're getting consistent results, otherwise it's very distressing and very confusing. So they're raised in the majority of neuroendocrine tumours, but not in absolutely all. And then there's prognostic indication there. We do get a lot of false positives, and we get some false negatives. In other words, there's some tumours that don't produce chromogranin A. It's a large complex structure, and it's many cleavage points from chromogranin A, and the molecules produced depend on the processing. Now, in everybody, chromogranin A is processed to some extent, but when there's a lot of chromogranin A there coming from tumours, then it's processed much more obviously, and we're getting lots of different molecules. And if we look here, we find that that's a drawing representation of a chromogranin A molecule. I used to have a really nice drawing, and it was a drawing of a 2-year-old, which was just a 2-year-old who was angry, who was drawing, and they just did it like this on the page. And chromogranin A is very complicated and very convoluted, but in fact we draw it out here to make it look easy. So there's lots of cleavage points marked in red, and there's lots of different molecules that we can get from this. The DACO assay, which we use in Belfast, measures the bit that's marked there, and pancreastatin we measure as a prognostic indicator in Belfast, but different assays will measure different parts of this molecule. Now, when I talk about pancreastatin, and I've left this out of the talk actually, I want to say one thing, that we can measure any of these fragments either in the middle of the fragment, so you could measure pancreastatin right in the middle of the purple bit, and it'll tend to measure the whole of chromogranin A. But if you measure it at one end, and the ends are only liberated when this cleavage occurs and when it's broken up, then you'll measure the pancreastatin, and we find that's much, much more interesting, and that's what's a good prognostic indicator. So, complementary to chromogranin A, we might have chromogranin B and secretogranin 2. It might end up being more sensitive and more specific and less, but unfortunately with these two molecules there are less sensitive assays at the moment, and they're not really looking terribly exciting right now, but it's something for the future. This is a really busy slide. It looks at all, well not all, but many of the neuroendocrine tumours down the side. And across the top, it takes chromogranin A in a very pale mushroom colour. It takes chromogranin B in a pale green, and then it goes on to a turquoise colour for secretogranin 2. And it looks at many of the different fragments that have either been looked at in tumours or in the circulation, and some of them are yeses and some of them are nos. If we look at the appendix, for example, we don't often get chromogranin A there, and we don't often get pancreastatin. But in fact, there's some indication in one group has said that we do get secretogranin 2. If we look at another tumour, a carcinoid of the rectum, then sometimes we don't get chromogranin A, but we do get chromogranin B, and we do get one of the fragments of secretogranin. So there are some possibilities that some of the more difficult tumours to follow might have some significant results at looking at this group of big proteins. So if we're going to look for novel markers out there, absolutely novel, what do we have to do? We have to maybe collect specimens of tumours. We have to mulch them all down and look at the proteins. And we do that with techniques in the lab. And then we need to purify these molecules. And we can do that in high-performance liquid chromatography or high-pressure liquid chromatography. Then we want to determine exactly what we've got. So we want to look at the size, that's the mass, and we want then to compare the peptides that occur in each of the tumours. So if we've maybe taken 100 tumours and we've looked at what proteins are produced by these, we want to find other bunches. Are some of these tumours all producing the same things? Is this worth pursuing? It's a sort of a fishing exercise in some ways, but in fact a lot of information has been gleaned through doing this sort of procedure. So then we pursue the most probable looking peptides or proteins, and we determine the precise structure. That's exactly what amino acid follows, exactly what amino acid, so we can get a sequence. And then we synthesize this, we make an artificial one, and we can make lots of it. And then we investigate, does this have a biological activity? Is it doing anything? Is it maybe found around the edges of the tumour, and is it making the blood supply increase around the edges of the tumour? Is it making it more likely that the tumour will grow? So there's all sorts of interesting bioassays that we can look at to see if these peptides are doing something that is very significant to the tumour. Then we need to develop a method of measuring these, and that would be often radioimmunoassay or immunoassay of some sort. And then we have to look at the usefulness of the particular thing that we have isolated. Now, there's hundreds of these. We're doing a project between the United States and Northern Ireland at the moment with an institution in New York, and we're looking at about 50 tumour specimens, and we're also looking at about 200 blood specimens, some from the same patients and some from others, to see that if what's in the tumour is getting into the bloodstream, because then it is really very interesting if it's something novel. So we have newly discovered peptides, we have old markers with a new perspective, we have the Granin family that we could take another look at, particularly although Chromogranin A has been looked at extensively. We could look at Chromogranin B and Circulating 2. We have new markers directed towards tumour options, and that's what I'm going to talk about a little bit. We need predictors because we need to know whether tumours are progressing. When we think of predictors, if we look at some, people have told you today, and you know, that on the tumour cell there are many, many somatostatin receptors. That is, there are keyholes on the tumour cells, much, much more on the tumour cells than in any normal cell in the body. And the key that fits into that is somatostatin. And so we can use somatostatin scintigraphy or octreoscans to look at these, and we can tell where the tumours are. So in a way, we're looking at a predictor. If you have an octreoscan and it's octreotide positive, the scan, and it's showing where the tumours are, then logic tells us that somatostatin analogues will do something for that tumour. They'll bind onto those receptors, they'll fit into those keyholes, and somatostatin will actually at least hopefully hold the tumour at bay for a while. Now, there are some neuroendocrine tumours that don't have somatostatin receptors in high quantities. For example, medullary cancer of the thyroid tends not to have so many receptors and doesn't respond so well to somatostatin therapy, therefore. So this gives us a clue for the future with other things. So where treatments are extremely expensive and we would just be working in the dark and thinking, do we try this? Perhaps we could have something that would give a prediction of whether the treatment will work or not. You know how expensive it is to have an octreotide scan here. Well, I presume it's, if lutetium or yttrium was available in Canada, then it would be very many more times expensive. And in fact, if you're not going to have somatostatin receptors, then there isn't any point in using this treatment. So new drugs are being developed all the time. We've got lots of them. We have somatostatin analogues, and we've had those. And we've got somatostatin analogues now to some of the different receptors. There are 5 main somatostatin receptors on cells, 1, 2, 3, 4, and 5, and the somatostatin analogues that we've been using are mostly towards 2 and 5. But now we've got 1 to 1, 2, 3, and 5. Some other companies are producing somatostatin analogues to the individual receptors. So there's some things going on there. But we also have another group of drugs, and they've been talked about quite a lot here as well, tyrosine kinase inhibitors. And they get within, the drugs will get within the cell to slow down the pathway that is producing tumour growth. And in fact, we would be hoping to find personalised treatment for patients later on. We're looking ahead a little bit so that we don't waste resources and waste quality of life and waste everything on giving patients treatments that really aren't going to be effective and just going to make them miserable. And we stick with the treatments for individual patients that are going to be really productive for that patient. So we have chemicals within the cell, and we're hoping they'll often overflow into the circulation, and we'll be able to measure these, and they'll give an indication of the involvement in the tumour and an indication of a potential use for drugs. So this was looking more towards personalised treatment. There's a degree of personalised treatment at the moment because we have many options and we decide on which option is best next. So that's personal to an individual person and an individual tumour, but this might get more personalised. So discovery of novel circulating markers. There are general markers like Chromogranin A. There are specific markers like VIP for a vipoma. There's prognostic indicators, which are like pancreastatin, Chromogranin A, and like neurokinin A. And there's predictive indicators, and we don't really have so many of those, not in the circulation. We think of newly discovered peptides. We think of old markers with a new perspective because we have new ideas. We've advanced with treatments and we've advanced with information. So, in fact, sometimes it's worth looking back over old things that were in the literature 5 or 10 or 15 years ago. We have the Granin Family, which we have not fully looked at. And we have markers directed towards particular treatment options. How do we think of things? Well, when I got this title, I felt as though I was being asked to look into a crystal ball in some ways, to think where we are now and in 5 years, what will we be measuring that will really be helpful? We come to meetings and we meet together with groups of other healthcare workers, with other people doing research, and with you, the patients, because in fact you can tell us what the problems are, and often that triggers off ideas in our minds. So we get together as groups. Sometimes we have a tete-a-tete with one person, and by doing such a thing, we come up with new ideas, because there's sitting in a hot tub alone, yes, you do get ideas, but often you sort of doze off to sleep, and it's much better with another person. So often we have consideration with other people. Sometimes we just sit and think, and that's what I had to do when I was thinking about how I was going to look forward to what's going to come next as markers in the circulation. But at all times we have to keep an overall view of what's going on. We haven't to take one little bit of the multidisciplinary group and divide it up from the rest, because I am an absolute believer in the fact that we need the surgeons, we need the radiologists, we need the nuclear physicians, we need the endocrinologists, the gastroenterologists, the liver surgeons, we need the pathologists, we need the specialist nurses, and we need the chemical pathologists or biochemists like myself, and I probably left out some people. We need all to come together to keep that eye over everything and to get the overall view. So thank you very much for your attention.
Thank you very much, Joy. That was very heartening, and we have lots to look forward to.